Welcome to the World Congress of Neurology 2025 podcast series, the official podcast of the World Congress of Neurology leading up to our global congress this October in Seoul, South Korea. As usual, I am your host, Professor Tissa Wijeratne, and I'm delighted to remind you that in each episode we speak with some pioneering leading voices in neurology about their work, their session, and the future of brain health. And of course, we would dwell into their life story a little bit to make it interesting and inspiring and fun for all of you listeners from all over the world. Today, I'm incredibly delighted and thrilled and honored to be joined by the queen of peripheral neuropathy worldwide for a long time, Professor Mary Reilly, a very well-known neurologist from the UK, and a plenary speaker at World Congress of Neurology 2025. As many of you know, she's going to tell us on new therapies in inherited neuropathies, a session that speaks to both innovation and top-notch patient care. Mary, very warm welcome to you. Thank you for being with us despite your very busy schedule.
Thank you very much for having me. I'm really looking forward to the meeting, and it's really nice to be able to talk to you in advance and do a podcast.
Absolutely. Mary, let's start with your story. Just to remind our viewers, listeners, Mary is a pioneer in many fronts. I don't know which way to start. She grew up under the umbrella of super giants like late Professor P.K. Thomas, late Professor Anita Harding, in an unbelievable era in the neurology at that time. It's like a dream to think about those days. We only heard about little snippets and we only read about things. But we have the horse mouth today. I'm picturing a young, enthusiastic, super interested, curious Dr. Mary Reilly walking around with them. So take us back to that golden era and tell us how this story began. Sure. What made you to be interested in medicine, then neurology, and I would love to hear some of the stories that you would like to share with those
so I'm actually
unbelievable
not from,
people.
Yeah. So I'm not from the UK. I'm from Ireland. So I was born in Ireland and trained there. So I went to medical school I was born in the west of Ireland, and that becomes relevant. So I come from a small island peninsula off the coast of Ireland. And I went to medical school, University College Dublin. And it was during my undergraduate training I got interested in neuroscience. Just everything that was neurology was more interesting than everything else. And I had a fantastic mentor Michael Hutchinson, who was a neurologist in Dublin, and his lectures in medical school were so fantastic. So that's what got me interested in the field. And then in 1985, when I was a medical student, I did an elective in London. At that time, it was in the Middlesex Hospital. It was the first time I ever saw a nerve biopsy, and that kind of sparked my interest in that area. So then after my training, I worked in Dublin, did my intern SAG, a couple of years neurology register, and through Michael Hutchinson, I got an interview to work with Anita. So Anita wanted someone to come that was able to go back to Ireland, see the patients, the families, speak Irish, because some of those people only spoke Irish, and I come from what's called a Gaelic, that's an Irish-speaking part of the country, and also do the genetic research here. So I was very lucky to get the job. So I came to work with Anita as my primary supervisor for a couple of years research, and during that time got to know P.K. Thomas very well as well. So it was a very, very exciting time, because the first gene for Charcot-Marie-Tooth disease was described in 91. So it was all excitement here. First mitochondrial gene a few years earlier, and literally it was just beginning to happen. And I think that was what was very exciting in the lab. Anita was a phenomenal supervisor. I mean, she had just got her own professor chair 2 years earlier. And she was just, I would say she's the complete queen of neurogenetics, the first people to describe the association with mitochondrial disease, with genetics, the first description really of a good classification of CNP, and also a description of a classification of the ataxias. So it was a phenomenal experience. At the same time, I think what was really interesting was when I went back to Ireland to see the families. So these were patients who got onset of the disease in their late 50s and 60s, and they got a severe neuropathy, and they got severe autonomic neuropathy and cardiomyopathy. So they were emaciated, bedbound due to the neuropathy, postural hypertension if they sat up, supine hypertension if they lay down, diarrhea constantly, and huge fluid balance problems because of the postural hypertension and the cardiac failure. So it was very sobering to see these families, and there was absolutely no treatment. And also, to be fair, there was very little genetic counselling in those days, and the families knew this ran in the families right back from the time of the famine. So it sparked an interest for me in neurogenetics. It sparked an interest in peripheral nerve, but also, you know, as a young researcher, it was pretty tough going out there, seeing these families, realizing, you know, they'd really seen nobody else about these diseases, and realizing how difficult it is to have serious, debilitating, fatal diseases. These people lived on average 3 to 5 years with no treatments, but with the legacy in the family of knowing it was a 50-50 chance that someone had been affected. So I think it was good having the balance of being both out in the field, if you want to put it that way, and also in the lab here. But it was an amazing time here. When I came to Queen Square, I had done 2 years neurology registrar, and it was actually like entering a different, you know, world. I went to the first Gowers, which is the Grand Round, and I hadn't heard of a single disease they were talking about. It was like the rarer of the rare. So having done 2 years busy neurology registrar, thinking I was up to date, it was, you know, progressive myoclonic epilepsy, Unverricht-Lundberg disease, and all these rare diseases. So it was a phenomenal learning experience. And I was extremely lucky. So after that, then I did finish my registrar training, senior reg in London between Queen Square and Guy's and the Royal Free, and then was lucky to get a job because P.K. Thomas was retiring in the late 1990s, in 98, in Queen Square as a consultant neurologist.
Brilliant. How was it grew up around Anita? What was the magic that she had? Was it the passion, the unbelievable cleverness, the enthusiasm? Because there weren't, as far as I'm aware, there weren't any woman or female person in this very much sort of, I'm not saying this in a sort of a negative sense, almost sort of a men-driven field at that time.
Yeah, I mean, there was the first female consultant neurologist to be appointed in England, I think, was someone called Pauline Monroe, who's still with us, who was appointed in George's. So Anita was, she probably was the first female professor in Queen Square, I think she probably was. So what it was about her, she was incredibly clever, incredibly bright. She had huge enthusiasm. So she loved her subject and really hard worker. And she was also great fun. So she, you know, enthused you to be enthused with her. She was very demanding to work with in a good way. You did not do what she said. You did not come in and say, I hadn't time to do this over the weekend, or I haven't written that draft. It just was not, you just did not do it. So she was amazing in that kind of way. And she was, you know, she was an inspiration really to many of us. And, you know, she died in 95 very early, and actually the last social event she came to was my wedding. So it was it was very touching for me. I was very close to her, and you know, she was a huge loss, but also a huge inspiration really. And also you're right though, Queen Square at the time, I mean, when I arrived here, you know, it was like full of, and this is not in any way derogatory either, but it was full of Oxbridge men in grey flannel trousers and navy blazers. Now, I know you're wearing a navy blazer, just as I said that, but it was a very specific type of people. But actually, it was also a place where there were Australians, New Zealanders, people from all over the world. And it has been my experience, and looking at the staff now, that if you do well, you did well, and you got promoted here. It wasn't in any way difficult being from another country coming, I found it.
And the crew that was there at Queen's Care, from wherever they came from, they basically changed the world, wasn't it? We didn't have a field of movement disorders. There was absolutely nothing, as you said, for the peripheral neuropathy work and the
I mean, it was,
products.
I think, yeah, it was, you know, it's a national health system. So it was very much a national hospital. And one of the amazing things, even in my career, is you get to see patients from all over the country, from all over the UK. So you had an amazing patient base. And, you know, the hospital is about 170 years old now, the hospital. And in the 1950s, the consultants in the hospital decided they needed an institute because they needed to research their patients. So the philosophy of research here has always been translational before the word translation was invented. It's you study your patients. Therefore, the questions that you need to answer come from studying your patients. You take them away and try to address them and bring them back. So what I loved about it here, it was always based on patients and always based it on diseases rather than the other way around. And it still is. It's very much that's the philosophy here.
This is absolutely true. I think when the clinicians ask clinically relevant questions, although they probably would not have used these current day buzzwords like consumer driven or co-design or implementation science, they would ask the question, they would answer the question, and they would implement. And obviously the patient at the corner of every single thing. I think when you work passionately like that, you are never going to burn out because you work hard because you like it, you love it. And then
Absolutely. No, absolutely. And I think I remember when I was still in Dublin doing a register job, and I have a strong recollection of being asked to see a referral, one of the jobs you do and go and see someone else's patients. And I remember actually finding myself running up the stairs. I was so excited about going to see and examine this patient. I thought, this is clearly what I want to do. And I think neurology generally has, it's got that combination of both history and examination being incredibly useful. So that's what I love about peripheral nerve. It's still got both. And nothing replaces the clinical, encounter. Yes, there's loads of tests that are adjunctive, but nothing really replaces the clinical encounter. Versus I have a brother who's a consultant cardiologist now in the US, and in cardiology, it's very test-based. So I remember in our membership happened to be able to identify 4 murmurs to get the membership at one go. That's not relevant now because of their tests, but neurology is still so much based in clinical practice. I think that's one of the huge attractions for all of us in it.
I think we probably should need to remind our listeners that while you are the queen of peripheral neuropathy, neurology is the queen of internal medicine, isn't it? Because of the very thing that you just mentioned.
Yeah, it is.
Mary, that's a brilliant and superb story, and I still sort of mesmerize how it would have been to be surrounded by those giants, and especially Anita Harding also. My next question is, inherited neuropathies often feel distant from day-to-day neurology practice. I want you to remind our listeners, why should they be on every neurologist and trainees' radar in 2025?
I think that's a very good question. We sometimes feel that a little bit. It's not the brain. I know it's brain awareness, the other little bits coming off it, as somebody once said to me. So I think neuropathy is not uncommon. It's, there's 4 or 5% of the population will get neuropathy with time. And I think what is emerging is how common inherited neuropathies are. So first of all, I think of the inherited neuropathies, that those ones that are more or less a neuropathy and nothing else, like Charcot-Marie-Tooth disease, and then the more complex ones that have other diseases involved or other systems. So even CMT is the commonest inherited neuromuscular disorder, affecting approximately 1 in 2,500. It varies a little bit. So it is common. So that's the first thing to say in a genetic disorder way. It's not common in other ways. And if you take the complex inherited neuropathies, we reviewed this in 2017, and we found 157 conditions that were inherited that neuropathy was part of. We reviewed it again recently, and there's 255. So these include conditions like Friedreich's ataxia, spinocerebellar ataxias, hereditary spastic paraparesis, but also systemic diseases such as transthyretin TTR amyloidosis that affects the heart, the nerves, etc. So knowing about neuropathy is very important. The hereditary neuropathies are important because they're generally slowly progressive, but there are some very seriously progressive ones, but have a very high level of morbidity. So CMT1A, which is the commonest form of CMT, is what most people would think of, because 50% approximately of CMT is CMT1A, despite there being about 130 other genes. And most people think fine, slowly progressive, normal lifespan, nothing much to worry about. Do they really need a diagnosis? But I have patients who've had up to 17, 18 operations on their feet. So multiple patients with CMT1A have severe foot deformity. Each operation can take you out of normal life for up to 6 months in terms of rehab, etc. So very high level of morbidity. And if you look at affecting people's career choices, they're, having to retire early, the choices they have to make about children, etc. It's a massive issue. I think it's also a paradigm for understanding neurogenetic diseases. So what I've been astonished over the last few years with the advent of whole genome sequencing, long read, short read, etc., is we're beginning to find genes we never thought would be involved in inherited neuropathy and vice versa. And the overlap and interaction with the inflammatory diseases is bigger. So first of all, we have diseases. I would say now there's at least 20 genes I've seen causing CMT where patients were misdiagnosed as having CIDP and inflammatory neuropathy. And we now recently have published a gene which causes multifocal motor neuropathy with conduction block, but it's not that. It's a genetic condition. So there is nothing in neurophysiology that cannot cause genetic condition that isn't associated. So I think the blurring of understanding the mechanisms, and I think there probably are more genetic patients out there. The other thing, I have very little doubt that idiopathic axonal neuropathy, the vast majority of those of older age or middle age are due to genetics. So we discovered the gene for Canvas in 2019, and that now accounts for 34% of idiopathic sensory neuropathies at middle age. So it's the first starting of it. So they're common. They're also important to, because we learn a lot about how to treat genetic diseases by looking at the neuropathy. So there's been massive advances in spinal muscular atrophy, in Duchenne's and in other genetic diseases. And, spinal muscular atrophy, with the very severe type, the children will be dead within 1 year. So clearly, people were able to do genetic therapy, tests, they were able to do trials, and, the risks were worth it, and patients have done extremely well. But in something like CMT and many other neurogenetic diseases we deal with in neurology, these are often slowly progressive. And to me, there's a huge safety threshold to cross before we can proceed with these new genetic therapies. So I think the neuropathies are very interesting because they're a good way of learning about that, about thinking about that, about thinking how we would deliver therapies, about thinking what might happen in the future if we can treat the diseases that are nowadays fatal. So I think there's a lot to learn about it, but it is important. And I think if I was a clinician, the biggest thing, two things we always get taught as a medical student. One, don't miss the treatable. That, of course, is still very important. But two, don't treat wrongly. So the number of patients who've had IVIG and steroids who have genetic neuropathies but are misdiagnosed with inflammatory, particularly in childhood where it's very difficult if you don't have a long history, is huge. So I do think every practicing neurologist needs to have a working knowledge of the inherited neuropathies.
And having listened to Mary's lectures multiple times, I could remind viewers that it would be fun and you would enjoy, and you would definitely walk away with a whole lot of gems that would keep you in full good shape for the rest of your career. So I strongly encourage the visitors to Seoul in October not to miss that. One other question, how have therapies evolved, Mary, in these neuropathies, and what's truly new? Just to sort of unpack some of the things
Sure.
that are already available.
Sure. So basically, up till, certainly for Charcot-Marie-Tooth and those type of disorders, there are no treatments available. There's ongoing trials in a number of them, but as of today, there are no therapies to treat the underlying disease. There are, of course, therapies to treat pain, et cetera, but no therapies available. So two things have happened, I think. So traditionally, people would find the gene, try to work out how the gene causes the disease. So work out the pathogenesis of the disease, often in animal models. Then try to identify prospective therapies, take those two trials in animals, and very rarely have that crossed into humans because they haven't worked. That's been one of the problems. So that's the first thing. And I think of that really as pathogenetic therapy. You work out how the protein causes the disease and try to work treatment from that. And there are a few successes in others, and there's one or two trials going on in CMT. But the game changing really has been the ability to get to the DNA itself by either gene editing, gene silencing, such as antisense siRNAs, gene replacement with viral-mediated gene replacement therapies, and the multiple new gene editing therapies. And I think that's already in place for TTR amyloid. I mean, it has totally changed my practice in the last 5 years because this is now a treatable disease and therefore cannot be missed. But the safety threshold to get into treatments for CMT is higher because most of these patients do not have a fatal disease. There also, it has unearthed the problem of delivery. Now, we've heard about that in the central nervous system with Huntington's disease and many of the Alzheimer's. How do you get it in? But at least in the central nervous system, you can get it into the CSF. There is a blood-nerve barrier. And the problem is the amount of stuff you'd have to give intravenously to get into nerves could be quite toxic to the liver, etc. So do you give it intravenously? Do you give it intrathecally? And there are now a lot of people working on the research of how you can get across the blood-brain barrier, what you can do to the therapy like an siRNA or an ASO to get it into the nerve or into the Schwann cells without causing the toxicity. And that's, to me, one of the biggest challenges, but a huge amount of development going on in that in the last year or two. So I think that's an important one. I think the second thing, which is absolutely fascinating. We're now treating diseases that used to be fatal. So what will SMA look like in 10 years' time? So none of those children would have been alive. So TTR amyloid, 85% is produced in the liver, 15% in the retina and the choroidal plexus. And yet our therapies are only against the liver. So we can knock down production in the liver completely and therefore stop the progression or prevent the progression of the cardiac disease and the neuropathy, which are still producing it in the brain. And we know from people who had liver transplants in the past that about 10 or 15 years after the transplant, you begin to get TTR CAA amyloid. And we never saw that in the past because people died of the disease before they would get that. So we will have a new problem very soon. We're going to have CNS TTR amyloid because we've treated the patients and none of our drugs cross the blood-brain barrier. We're going to have to look at that. So it is interesting when you start off like I did in the peripheral nervous system, and I'm now back into the central nervous system with the disease. And I think across the whole of neurology, we're going to start seeing these diseases, which we didn't see. And that may explain why many ubiquitously expressed proteins don't cause ubiquitous disease because people didn't live long enough. So I think that's a really interesting issue. And then the second issue with developments of treatment is, so, we know from ordinary practice that if you give a drug to one person and another person, they will have different efficacy of different side effects. We're only beginning to scratching at the surface of understanding that with genetic therapies. So it's probably that your own other genetic environment, your epigenetic environment, your own immune system will determine your response to these treatments we're going to give. So there's a whole new world of neurology and a whole new world of medicine, iatrogenic in a totally different sense that is emerging from gene therapies that'll keep people going for many decades to come.
Absolutely fascinating. Mary, what do you think if you were to go to a pub in an afternoon with sort of reborn late Professor P.K. Thomas and the Anita Harding, miraculously, what would they think or what would they say, having seen where things have come up by 2025?
I think that's really interesting. So Anita Harding died in 95, and she was famous for within a few days of her death, on her deathbed, saying, "At least I don't need to get to know Word Perfect 95 or whatever, which was the new version of the computer." I think they would both be fascinated that we have therapy. So I feel myself, and I think they would be the same. When I started in this area, I really felt it should be all pathogenetic therapies. We'd work out how the protein causes the disease and treated that. I did not envisage we could ever get in to edit DNA permanently or get in to replace it. And I think Anita, if she saw SMA, if she saw the treatment out there, anybody that has seen those videos of the children, if they saw what you could do, would be absolutely fascinated and delighted. And I think, what we've been able to do with genetic diseases just shows you there's nothing that cannot be done. So all those horrible diseases we're dealing with now in the brain that seem accessible, that seem untreatable, they're not. We just haven't got there yet. So it's like, genetic diseases is the infections of 2 centuries ago or of the last century. So it is the mountain we're climbing at the moment. And there'll be other ones. There always is. I mean, I think COVID just gives us an example of how life can throw complete curveballs at the whole world, and we have to deal with it. But it's why nothing is quiet and nothing is silent in medicine. It's why it's endlessly fascinating. And I think despite many of us, I'm sure you would feel the same, there's always problems. There's problems with funding, there's research funding, there's clinical funding, there's problems all around the world, with huge problem with genetic diseases, with equity and access to therapies. That's going to be a major issue going forward, as it was with HIV therapy and still is. But, it is such a fantastic area to be involved with. And so how anyone could do anything else other than neurology makes it, I really don't understand.
100%. I was just thinking the same thing. If you are a medical student or a physician trainee accidentally listening to this podcast, I can't imagine that I would think of anything else other than neurology. For the last couple of points that you raised, neurology community is now taking things head on. We have almost made brain health a household name over last 12, 14 years. You can see that major neurology societies changing their tagline to brain health for all. And we are captivating that, and we are bringing humanity back to humans. I think neurology crew is doing unbelievable things in all corners, isn't it?
So no, absolutely. And it's very much based on humans and on people. It's all, I again go back to, it's the clinical, it's what someone is saying, it's what you find examining them, it's their disease, and it's in a way that I think because it's the whole body. I mean, the autonomic nervous system interacts with the gut, the heart, everything. So it's the master controller of everything. There's no question about that, and therefore is the most important thing to get right.
100%. And Seoul, the Korea, the World Congress Neurology 2025 is the best, one of the best neurology congress with different colors, different costumes from all over the world. It's an unbelievable experience. I mean, any neurology meeting is great, but this is extraordinary with that
Well, the World
diversity.
Congress of Neurology, it's just, those meetings are unparalleled because of the breadth they cover. I do remember, the one I remember that probably affected me most was Chile. I mean, I heard of diseases in Chile, in South America. I must have heard of 100 infections I'd never heard of before. So it was the ability to see stuff, and I'm sure the same will happen in Korea. It's the ability to see way beyond what we do in our own practice and learn from each other. I learned more there than I've done in many other places just from listening to people having experience of these kind of diseases.
Completely agree. Mary, your session promises insights into emerging therapies. Without giving too much away to this podcast, just cover some of the big questions or hopes you will be exploring for the audience during this plenary.
So what I will do is I'll explore where we are with therapy development, which is a lot of it still at the preclinical, but some of it in clinic space, particularly with the gene therapies. That's the siRNA for PMP22, which is CMT1A, because it's the commonest type and, will most likely come to a clinical trial end of this year, beginning of next year. But also the gene replacement and some of the other rare ones and a couple of clinical trials I'm doing myself. I will highlight 2 or 3 things as well as that excitement. Number one is the huge problem of VUSs, variants of unknown significance. They are a massive part of diagnostic practice. And for someone to get into a clinical trial or in the future to get treatment, we'll need to know if the variant is pathogenic or not. And to me, that's it's not talked about yet because it's not a problem. It will be a problem very soon. Number 2 is delivery. How do we deliver the therapies into the peripheral nerve system? That is the Schwann cell, the cell body, or the axon, depending where they are. And how do we do that safely? And there's a lot going on in that. And number 3, which is a particular passion of mine, is I really feel you have to be absolutely sure you have the tools to do a clinical trial to get the answer. There's no point having a fantastic treatment, knowing you'll do a clinical trial, but knowing the tools you're using, the outcome measures, will not tell you the result. And there is some tension between researchers and the FDA, EMA, MHRA, etc., between what tools you can use. So I think we have an ethical responsibility to do trials in a way that will answer the question. And I personally will not do a trial if I think it hasn't got the right outcome measures, because I think it'll waste the patient's time most of all, and lots of money and effort as well. So they're the kind of themes I'll be dealing with, but in a very optimistic, positive way. We're at a place which is a great place to be. To have these problems in itself is a great place to be.
Great. If I'm attending your plenary, what is the one big idea or shift in perspective you hope that I leave your plenary session with?
I think hopefully you will leave it and you'll have a wake-up call if you're a general neurologist saying, gosh, I need to know about this. I will talk about TTR amyloidosis, saying you cannot miss the treatable. And this is a hugely treatable disease. So I hope you learn with that kernel. And I hope you leave with knowing these are now treatable. There's lots of clinical trials coming on board. I need to be able to diagnose these, and I need to know enough to be able to go to find out if there's trials going on and to be able to inform my patients what's likely to happen. So I think it's from years ago, people thought often of neurogenetic diseases. Interesting, no treatments, not much benefit to the patient to know exactly what they have. I hope people will leave thinking that is no longer acceptable for all kinds of reasons, including not least, you don't want to treat your patients as an inflammatory disease if they haven't got one. So do no harm is still a very important part of medicine.
Absolutely, fully agree. Beyond your session, what makes World Congress Neurology 2025 such a valuable meeting for the neurology community worldwide?
So I think it's a very valuable meeting because I think there's a revolution in therapies generally. Obviously, I'm more up to date in the genetic therapies, but I've recently come back from what we call the International Peripheral Nerve Society and seen the first 2 cases treated with CAR T therapy for CIDP. So there's a huge revolution going on in the inflammatory treatments, often borrowed from cancer. They're there first because they've more serious disease in some ways. But what we're happening in CAR T therapies is absolutely incredible. And then what we're learning about checkpoint inhibitors. So we've all of these new therapies. And then what's happening in the headache world. So a headache, I grew up amitriptyline, stress headaches, or propranolol migraine. That was my background. Headaches were very simple. They were one or the other. There were none of these complexities. And now we have novel therapies based on the pathogenesis of headaches. And as for stroke, I mean, stroke has been completely revolutionized. Again, the idea that you could do clot retrieval. So I think it is at a really, I think if I would say, where are we at now? We're in the era of treatment. And that 100%. Is for neurology, for all our medical colleagues, we used to say, why would you do neurology? You make lots of clever diagnoses and you can't treat. Well, get real, we can treat.
We changed it. We treat better than anyone else.
Exactly.
In a human way. Mary, thank you again for joining us. We are looking forward to your plenary session and the important conversations it will inspire. To everyone listening to this podcast, please join us in Seoul this October for the World Congress of Neurology 2025. Thank you and have a wonderful day.
Thank you very much. Look forward to seeing you.